Mr. Chairman, thank you very much for your kind introduction. Dear colleague and friends, it is a great honor for me to be invited to 16th Turkish HPP Surgery Congress. Today, I talk about Eastern approach of BCLC-A in HCC. I think it is very interesting to compare Eastern and Western approach. I think the Turkey is the country where Eastern-Western difference should be discussed in this country because Turkey is in the middle of East and West. So I think it's very interesting topics for discussion. Only this? Mouse touch on? Mouse touch on. Okay. I have no conflict of interest. Actually, Turkey is our brother country. This is the Korean people is supporting Turkey team, soccer team, because we think in our mind we are brother country. Actually, the president of HB Surgery, Mustafa Kerem, Professor Mustafa Kerem and Professor Bulan and Professor Fatih has visited Korea and visit Korea, and we have a very good time together. I have many good friends because Mahir is there. Actually, we are close friends. Also, and Dulund is also a good friend, and Yaman Tokar is a good friend because we are having a good time with IASGO. And there are many good friends like Junaid, but I didn't include in my photo. About this BCH criteria, actually, my previous speaker, Dr. Winzel, has shown very well. Today, as already shown, I focus on early stage BCLC-A and the difference between the Western and the Eastern. There may be some difference between the Eastern and Western, but there are some difference in definition of large HCC. So I will speak about solitary large HCC, more than 5 centimeters first. Then I will talk about the resection for multinodular tumor. There may be some difference in opinion. And the previous speaker, Dr. Wenzel, already mentioned about dissection for cirrhotic. Because I'm a surgeon interested in the minimally invasive surgery, I speak about depending on the minimally invasive surgery and the procedure. So minimally invasive surgery is my focus on this those topic as well. How about large HCC? As you know, the single lesion, most of the patient is less than 5 centimeters. But if tumor is larger than 5 centimeters, the prognosis may be different from HSK-A. So that's why we have reported on how about single and large HCC in HCC. So we have classified single large, more than 5 centimeters, as group X, just temporary group X, and we have compared with the PCS stage A and the PCS stage B. About 10,746 patients, the group X, a single lesion, more than 5 centimeters, has 418 patients, and group A is 2,787 patients. Group B is 760 patients. We have compared the propensity score matching, and Group X is 116. Group A, Group B, same 116 patients. We have analyzed the survival curve. When you compare the survival curve between the A and Group X, there's a difference between Group A and X. And Group X is very close to Group B. So we think although Group X is classified as Group A, if the tumor is larger than 5 centimeters, I think it is very close to Group B. This is another study from China, and also they have reported on the single large nodule more than 5 centimeters. They have classified more than 5 centimeters as a BCLC-A2, and they compared the prognosis of the patient. If you look at this, this group A2 is more than 5 centimeters, and this survival curve is very similar to group B. So I don't know, maybe there's some change in the future, but anyway, group A2, which is single, more than large 5 cm, more than 5 cm, large HCC is very close to type B in the survival. So anyway, if the solitary tumor, which is larger than 5 centimeters, may be better defined as BCSP in the future, I don't know. But this is as Asian, Eastern thought on about large HCC. How about, and also about the treatment for the BCLC-A. Actually, EASL, AASL has resection and transplantation, ablation, and but this is from the China. In Eastern country, we think resection can be performed from BCLC-A to BCLC-B as well. So if you see about some report from the China, AASL may think a liver resection is first-line therapy, but EASL restrict only a single HCC. But in Asian country, liver resection can be indicated more widely, and some meta-analysis show that the improved survival of liver resection of TAC. Actually, previous speaker already showed that the difference between the liver resection and liver transplantation is becoming very narrow. And about multinodular, I speak about later. Anyway, in this report, they had commented that the laparoscopic approach is preferred because it has advantage of less blood loss and similar long-term outcome. I show this laparoscopic approach. Because we are talking about large-sized tumor, is there a role of laparoscopy for large-sized tumor? Actually, the large-sized tumor in first consensus meeting, it was not well indicated for liver surgery, minimally surgery. Recently, we have analyzed our data of large hepatocellular carcinoma by propensity score matching. This is written by our international fellow, Dr. Wedit from Thailand. We have performed the propensity score matching, and laparoscopic hepatectomy is 70 cases, open hepatectomy also 70 cases, and we compared open and laparoscopy, but laparoscopy has a shortened hospital stay and similar blood loss and similar ideal resection rate. About the survival, this is the survival. This is before propensity score matching. This is disease-free, recurrence-free survival and overall survival. In large HCC has been contraindicated for laparoscopy, but there is no difference. After propensity score matching, This is recurrence-free survival, this is overall survival. There is no difference. Actually, laparoscopy has tendency of better survival anyway for large hepatocellular carcinoma. I think if we extend this section, we can have a better survival in large hepatocellular carcinoma as well. Then we move to the another maybe some difference between the Western and Eastern dissection for multinodular tumor. This is the multinodular tumor. Usually, ablation and transplantation is indicated because of recurrence. Actually, this is the slide I have shown before. In multinodular HCC beyond the Milan criteria, dissection may have good overall survival over TACA. Multiple lesion is actually, as a laparoscopic surgeon, multiple lesion is a little difficult because we need multiple dissection. By laparoscopy, multiple lesion may increase operation time and bleeding may increase, and sometimes it's difficult in location of tumor and the palpation is difficult. So actually, multiple dissection is has been relatively contraindicated by laparoscopy. This slide I already have shown. Recently, we have compared laparoscopic versus open liver dissection for multiple hepatocellular carcinoma within and beyond the Milan criteria. This is a collaborative study between this is written by Dr. Gianluca Cassese, who is from Italy. So this is collaborative study between Italy and our institution. So if you look at whole patient, this is overall survival and disease-free survival. And the laparoscopy have 5-year survival of 48, around 50%, and disease-free survival is 20%. There is no difference. If you look at beyond Milan, overall survival is around more than 35%, and disease-free survival is about 20%. Anyway, multinodular tumor, actually BCLC criteria A, they say in Western, it is usually recommended for ablation or liver transplantation, but after surgery, the outcome survival is not so bad. So in this report, we have summarized that liver dissection for multiple HCC can be safe and effective in selected cases, and this laparoscopy may shorten hospital stay without affecting long-term outcome. Is our summary for multiple HCC. So anyway, the large HCC, multiple HCC, maybe we can apply laparoscopy in this. Anyway, sometimes we perform cell-based hepatectomy for recurrent hepatocellular carcinoma. When there is a recurrent hepatocellular carcinoma, we perform a radiofrequency ablation, then we perform a cell-based hepatectomy. So in this graph, the blue is cell-based hepatectomy. The green is a primary hepatectomy. So we compare the disease-free survival and overall survival. Disease-free survival, cell-based hepatectomy has worse prognosis, but overall survival is similar between primary hepatectomy and primary hepatectomy and the cell-based hepatectomy. So if even if the patient recurrence, we can do ablation, then you can do cell-based hepatectomy. That's why liver dissection survival is increasing. So we do dissection, we do ablation. So even if recurrence, so we can do. That's why the gap between the transplantation and also resection is becoming more and more narrow. Lastly, I talk about resection for cirrhosis. Actually, surgical resection is recommended only for non-cirrhotic patient. For cirrhotic patient, we have to think about many factor, multi-factor. This is a EASA guideline. And also this is another report. EASA, AASLD guideline indication only single HCC with preserved liver function without portal hypertension. This guideline may exclude the operation, but selected patient with portal hypertension can be resected because there's a donor shortage, and also recently survival outcome of liver resection is becoming better. This is the AASLD guideline about this year. AASLD guideline says that for single lesion without portal hypertension, then surgical resection. If there is a portal hypertension or multiple lesion, they recommend liver transplantation. This is reported in this year. But because minimally invasive surgery approach may permit safer surgery and decreased physiological disruption, so low risk of complication. So minimally invasive surgery may extend the resectability criteria. This is also reported in the same journal. Lab liver resection has advantages, many advantages like small incision, less pain, short hospital stay, fast recovery. But in chronic liver disease, lab liver resection has advantage of decreased instance of liver failure. This is a report of our institution of laparoscopy versus open liver resection for HCC. We have a case match analysis. Survival outcome is similar between the laparoscopy and open surgery. In this study, we have analyzed the complication about the liver failure, transient liver failure. Laparoscopy is 3.4%. Open liver resection is 8.9%. So by using laparoscopy, liver failure can be decreased even if it is a transient liver failure. This is another study with a international collaborative study. So I have a privilege to be one of the co-authors of this study. In this study, we also have analyzed our complication, open versus laparoscopy. If you look at liver failure, in major hepatectomy, liver failure is in open surgery is 11.8, but minimally invasive surgery is nil. So I think minimally invasive surgery has advantage of decreased liver failure. I'd like to show our some report in 2016. We have analyzed our 10-year experience of laparoscopy liver resection for HCC. For HCC, I think this is not well indicated in Western criteria. Liver cirrhotic patient is 141 patient. Non-cirrhotic patient is 91 patient. When he compared non-cirrhotic versus cirrhotic, the cirrhotic is green line and non-cirrhotic blue line. In disease-free survival rate, non-cirrhotic is better than a cirrhotic patient. But for overall survival, is similar, almost same. So if the patient has more recurrence in cirrhotic patient, but if we do ablation, we do resection, I think the survival outcome is similar between non-cirrhotic. Anyway, that's why for cirrhotic patient, I think resection has a role. But if the patient has a very severe liver failure or cirrhosis, chronic liver disease, we have to do transplantation. So I will introduce our experience of total laparoscopic donor hepatectomy 2010. As you know, I think it is very similar to Korea and Turkey. There is many, DDLT is not common in Korea, so we have to do LDLT. So because for LDLT, to save patient life, donor surgery is inevitable. But if we do open donor surgery, there's a big scar. So we think about laparoscopy in living-related transplantation. This is the first report by Daniel Sheki for pediatric patient. So in eastern side, in Korea, we are very much interested in the LDLT. That's why I started laparoscopic donor hepatotomy in 2010. This is the first patient in 2010, and this is a trocar placement. And we are operating about 13 years ago. And this is the trocar placement at the operation room, and this is the scar after 7 days after operation. Anyway, this right donor hepatotomy was shown in many newspaper in 2010 April. Actually, this was reported a little later than my colleague, Dr. Sobrang and Fernando. I think they have reported 2012, but I performed 2010. But everyone knows that I did it first, donor right hepatotomy. That's why in 2016, I have expert consensus meeting for laparoscopic donor hepatotomy. This is the picture after expert meeting for donor hepatotomy. Because this was held in IASCGO meeting, at the time, official journal of IASCGO is digest surgery. So I reported in digest surgery of expert panel statement of laparoscopic living donor hepatectomy. The summary was laparoscopic donor hepatectomy recommended in high volume center for laparoscopic surgery and LDAT center. Experts agree that laparoscopic donor surgery can be a standard practice for pediatric LDLT. But adult LDLT, in near future, there may be more adult LDLT. Laparoscopic donor hepatotomy is a developing technique, but it should be performed with a highly proficient surgeon with extensive experience in donor hepatotomy and laparoscopic resection and LDLT. So anyway, now in Korea, many centers is performing this laparoscopic donor hepatectomy. Anyway, in 2016, about 7 years ago, we have expected that this surgery will be more used in the future, and now, 2023, 7 years later, many centers in Korea is using laparoscopic donor surgery when you need LDLT. I think everything changed. Nothing remains without change. I think for HCC and minimally invasive surgery, many things have already changed. I'd like to finish my speech by introducing ILLS 2025. ILLS 2025 will be held in Seoul in June 24-27. I think you know Gangnam Style. The center of Gangnam Style is COEX. Some of my colleagues may have joined the 2014 ISPBA in Seoul. This was held in COEX. COEX is a very good place for shopping and amusement. I welcome all of you to ILLS 2025 in Seoul. Thank you very much for your kind attention.